Good afternoon, everyone. Welcome to Medical Grand Rounds. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which the people of the world now gather. We're very fortunate to have a speaker from the Division of Medical Biochemistry, and I'd like to ask the chief of this division, Dr. David Blank, to please introduce our speaker. David.
Hi, good afternoon. Last week, we had all heard from Dr. Jacques Genet, who provided us an overview of clinical lipidology focusing on cholesterol. This week, we have Dr. Alexis Baass, who's going to focus on severe hypertriglyceridemia. Dr. Baass is a medical biochemist and lipidologist at the MUHC since 2010. He did his residency training at University of Montreal, and he completed an MSc at McGill. He's the head of the ICRM lipid clinic and also has a lipid clinic in the Division of Endocrinology here at the Glen site. His research is in the field of familial hypercholesterolemia and, not surprisingly, hypertriglyceridemia. He's a lead investigator in numerous clinical trials, and he's a founding member of FH Canada. He's published more than 120 peer-reviewed articles and abstracts, which have been cited more than 2,400 times. And I will stop here, and I will let Alexis take over.
Well, thank you very much for the introduction, David, and thank you for the invitation, the opportunity to present at the Medical Grand Rounds. So as mentioned, we had an excellent presentation by Dr. Genet, so we know everything about LDL, genetics, and cardiovascular disease, but many clinicians still don't know what to do with triglycerides. So today we're going to talk about hypertriglyceridemia, focusing on the severe hypertriglyceridemia. Okay, so here are my disclosures. So I received some research grants from different organizations. I participate in multiple clinical trials for patient care and sit on advisory boards for different companies here. And so here's the outline and the objectives of the presentation today. We're going to talk about the metabolism of triglyceride-rich lipoproteins. We're going to define hypertriglyceridemia. We're going to talk about the link between hypertriglyceridemia and atherosclerotic cardiovascular disease. And then we'll focus more on chylomicronemia, which is severe hypertriglyceridemia. So differentiating the monogenic form versus the multifactorial form. We'll talk about the link with the multifactorial chylomicronemia and pancreatitis. And then we'll finish talking about a clinical management of chylomicronemia and pancreatitis. So what are triglycerides? I think it's important to put things in context. So triglycerides are composed of glycerol backbone esterified with 3 fatty acid groups that can be of various length and saturation. So mostly triglycerides are a source of energy. They're a way to transport and store fatty acids. So 1 gram of triglyceride is roughly 8 to 9 calories. They have other functions, as structural functions. So triglycerides are the main components of intracellular lipid droplets and are components of the lipoprotein core of the lipoproteins. And the fatty acids of triglycerides are also a precursor to the synthesis of components like prostaglandins, for example. All right, so what is hypertriglyceridemia? Unfortunately, there's no global consensus. The Canadian guidelines have certain cutoffs. Americans use roughly 5.6 millimoles per liter as the definition of severe hypertriglyceridemia, but I much prefer the European recommendations. So in 2014, the EES published this consensus redefining hypertriglyceridemia. So mild to moderate hypertriglyceridemia would be triglyceride between 2 and 10 millimoles per liter. Severe hypertriglyceridemia is triglyceride above 10 millimoles per liter. Certain cases, we could say very severe is above 20 millimoles per liter. So in the primary care settings, and this is data from roughly 10 years ago, 25% of Canadians have triglyceride above 1.7. Most likely this has increased because of the increased prevalence of obesity and diabetes. So based on Canadian Health Survey data, we can say that 10% of women, 20% of men have triglyceride above 2 millimoles per liter. and 0.1% of the population have triglyceride above 10. So it's not that frequent, but again, it's not that rare either. When we talk about the very severe forms, we're talking about 0.01% of the population. So here, if you look at this distribution of triglyceride in the population, this is not a distribution following a Gaussian distribution. It's a log distribution skewed towards the high values. And if we look at the 95th percentile, this corresponds to a triglyceride around 3 millimoles per liter. So let's talk about the metabolism of these triglyceride and triglyceride-containing lipoproteins. So after a fatty meal, so fat gets digested, absorbed by the enterocyte, and in the cell, enzymes like DGAT will esterify fatty acid to form triglycerides. And these triglycerides are packaged with ApoB48 through the action of other enzymes like MTP to form these chylomicrons. And these chylomicrons are dumped in the lymphatic circulation that then gets transferred to the systemic circulation. These chylomicrons have many different proteins on their surface, ApoE, ApoA5, C2, C3, etc., and can be hydrolyzed through the action of lipoprotein lipase. So LPL, lipoprotein lipase, is produced mostly by myocytes and adipocytes. So these are the tissue that will express LPL. So LPL is present at the level of the endothelium of these tissues and will hydrolyze the triglyceride core of these chylomicrons, releasing free fatty acids that are taken up by these tissues and leading to these remnant lipoproteins that are very rich in cholesterol and atherogenic. These are then taken up by different cells like hepatocytes, for example. So this is what happens postprandially. After a meal, we produce chylomicrons. In the fasting state, the excess fatty acids in the hepatocyte also can be transformed into triglycerides through the same enzymatic pathways. And these triglycerides can be packaged with ApoB100 this time to produce these VLDL, very low density lipoproteins. So these are triglyceride-rich lipoproteins, similar to chylomicrons, but significantly smaller. Again, at the level of the circulation of adipose tissue, muscle tissue, LPL can hydrolyze the triglyceride of these VLDL, leading to the formation of intermediate density lipoprotein, again, very atherogenic lipoproteins, that at the level of this hepatic sinusoid will be further metabolized by hepatic lipase to give LDL, low density lipoprotein, again, an atherogenic lipoprotein that can be readily taken up by the LDL receptor at the cell surface. All right. So let's focus on the LPL modulating genes or proteins. So LPL, there's many different cofactors. LMF1 is a chaperone that allows the translocation of LPL at the level of the endothelium. LPL is bound to GPIHBP1, so glycosyl phosphatidylinositol anchored high-density lipoprotein type 1. So it's held there at the level of the endothelium, and it can interact with the circulating triglyceride-rich lipoproteins. So there's several activators like ApoA5, ApoC2 that will increase LPL activity, and there's several inhibitors that will reduce activities such as ApoC3, ANGPTL3, ANGPTL4. And the ratio of these activators to inhibitors depends on many factors such as insulin and will play an important role in determining the efficacy of lipolysis by LPL. Okay, so let's talk about secondary factors that can lead to high triglycerides. So secondary hypertriglyceridemia. So we know this from the clinic, excess calorie intake often associated with high blood sugar, but also high triglyceride. Excess alcohol consumption can raise triglyceride very acutely and for prolonged periods as well. Increased BMI can be associated with high triglyceride, insulin resistance, metabolic syndrome, type 2 diabetes, other conditions like pregnancy, SLE, and of course, medication like steroids, corticosteroids can also increase triglycerides. In the clinic, we frequently see patients with primary hypertriglyceridemia. So we can separate them in two groups, mild to moderate hypertriglyceridemia with a triglyceride between 2 and 10. So the most frequent cause we see is multifactorial hypertriglyceridemia, previously called the type 4. These are patients that accumulate VLDL in circulation. It's often a polygenic condition with an important contribution of secondary factors. Often we also see patients with a mixed dyslipidemia, both high cholesterol and high triglyceride, previously called the type 2B dyslipidemia. These patients have both LDL and VLDL in circulation, again, a polygenic condition with secondary factors. More rarely do we see this form of mixed dyslipidemia called dys-beta-lipoproteinemia, previously called type 3, a very atherogenic condition due to the accumulation of intermediate density lipoprotein, and an ApoE dysfunction is the underlying cause, often with secondary factors contributing as well. But more importantly, we see these patients with very severe or severe hypertriglyceridemia with a triglyceride are above 10 millimoles per liter, of which there's two conditions. The multifactorial chylomicronemia syndrome, previously known as the type 5, where the accumulation of VLDL and chylomicrons. This is mostly a polygenic condition, but large effect variants like mutations in LPL can contribute, and there's an important contribution in secondary factors. And we do rarely see these patients with a purely genetic form of severe hypertriglyceridemia called familial chylomicronemia syndrome, FCS, previously called type 1. These patients have lots of chylomicrons in the circulation, and it's, as I mentioned, a monogenic disease. Higher triglyceride are associated with a higher prevalence of mutations in LPL and its associated cofactors, whereas mild to moderate hypertriglyceridemia are more of the domain of the polygenic and multifactorial. So why are we even interested in triglyceride in the first place? Well, we all know that triglyceride is a risk factor for acute pancreatitis and can increase the risk very significantly. We also know that, unfortunately, triglyceride is also a risk factor for cardiovascular disease, so especially a factor for residual cardiovascular risk. And we know that there's a strong association between hypertriglyceridemia and hepatic steatosis as well. So these are three morbidities that are associated with this condition. So let's talk about association between hypertriglyceridemia and atherosclerotic cardiovascular disease. So we have many studies, observational cohort studies of many trials that show that there's a strong association between triglyceride and atherosclerotic cardiovascular disease, independently of other risk factors, other lipid risk factors such as LDL. And it's thought that this is probably due to the concentration of triglyceride present in IDL and these small VLDL that are pro-atherogenic that can enter the intima media space and cause atherosclerosis. So these studies have shown that a 1 millimole increase in triglyceride is associated with a 1.4 to 1.8 relative risk increase in atherosclerotic cardiovascular disease. So there was a controversy back in the days. Prior studies suggested that maybe the association between ASCVD and triglyceride was secondary to the inverse relationship of triglyceride with HDL. So most patients that have high trigs have low HDL. Most patients with high HDL have low trigs. And it was thought that HDL was the causal factor and triglyceride was perhaps a bystander. But we had recently, in the last 10 years, some very nice Mendelian randomization studies that showed that there's a direct causal relationship between genetically elevated triglyceride that was studying through mutations and SNPs and atherosclerotic cardiovascular disease. Whereas we can't say that genetically calculated HDL is associated with cardiovascular risk prevention. So actually the hypothesis was wrong. There's actually triglyceride being probably the causal factor and HDL perhaps being the bystander in this situation. So what are the cardiovascular events that are increased with hypertriglyceridemia? As we mentioned, it's probably not directly the triglyceride, whereas the cholesterol associated with these triglyceride-containing lipoproteins, that's atherogenic. So many studies, including the Copenhagen General Population Study, the Copenhagen City Heart Study as well, have shown that elevated remnant cholesterol, so these are cholesterol and intermediate density lipoprotein and small dense VLDL, are associated with myocardial infarction, peripheral artery disease, and ischemic stroke as well. So in the clinic, how should we approach patients with hypertriglyceridemia to reduce the risk of atherosclerotic cardiovascular disease? Well, as we mentioned, in statin-treated patients, hypertriglyceridemia is associated with the residual cardiovascular risk. So in subjects with hypertriglyceridemia, so triglyceride above 2, we could say that we should probably select a non-HDL target or an ApoB target rather than an LDL target to better address the ASCVD risk associated with the hypertriglyceridemia. So one of the most important approach is intensification of statin therapy to further lower the non-HDL of the ApoB in these hypertriglyceridemic subjects. Other therapies could also be useful. We could perhaps use ezetimibe as well. Some older data show that perhaps fibrate may have an additional reduction in ASCVD risk in hypertriglyceridemic patients with low HDL and diabetes. So we have some older data there. Newer data shows that omega-3, specifically icosapent ethyl or Vasipa, is associated with a further reduction in ASCVD risk in hypertriglyceridemic patient with secondary cardiac prevention or in hypertriglyceridemic patient with diabetes. So that could be another option. But we have many other new options, novel therapies that are under investigation, targeting other types of basically LPL inhibitors, such as ApoC3 and ANGPTL3. So there's studies in mild to moderate or high hypertriglyceridemic subjects for the reduction of atherosclerotic cardiovascular disease. All right, so now let's talk about severe hypertriglyceridemia or the chylomicronemia. So chylomicron are usually cleared from circulation 3 to 4 hours after a meal. So chylomicronemia is when these chylomicrons are present in the fasting state, so in a fasting blood test. So chylomicrons are usually present when the fasting triglyceride are above 10 millimoles per liter. So this can easily be observed by the lactoscent plasma. If we want to differentiate the lactoscents due to VLDL rather than to chylomicron, one test is to put the tube in the fridge. The chylomicrons are much larger and much buoyant, and after 24 hours, they will migrate to the top and form this cream layer. These are basically triglycerides. Patients with chylomicronemia are also at risk of developing lipemia retinalis. So basically, this is a physical finding of high triglyceride and eruptive xanthomas as well. So how do we differentiate patients with the monogenic form of chylomicronemia versus the multifactorial form? And why is it relevant? We'll talk about that in a second. So FCS, or familial chylomicronemia syndrome, is the monogenic disease. It's a disease of chylomicron accumulation. So it's a disease that has a low prevalence, affecting 1 in 100,000 individuals to 1 in 1 million. But certain regions of Quebec can have a much higher prevalence, 1 in 10,000, the Saguenay-Lac-Saint-Jean region, due to genetic founder effect. And this FCS is thought to cause roughly 1 to perhaps up to 3% of cases of severe hypertriglyceridemia. So this is an autosomal recessive disease, meaning you need 2 mutant alleles in genes associated with LPL activity. So either LPL, so most of the time your mutations are in the LPL gene, but other modulating genes can also be causal of FCS as well. So it's a disease that's mostly a genetic disease. The secondary contributing factors play a minimal role. It's a disease of pediatric onset. You're born with it. Sometimes it occurs later in life, but unfortunately, often it's diagnosed later in life because people don't know about this condition. The prevalence of pancreatitis is very high. 60 to 80% of patients will at least have 1 episode of pancreatitis. And it's quite a debilitating disease. Patients have often episodes of nausea, vomiting, recurrent abdominal pain, and many studies have shown that they have a poor quality of life. They can't really eat fat. They can't go to restaurants. They have to have a very severe diet. These patients have a high frequency of eruptive xanthoma, lipemia retinalis, as we mentioned, and hepatosplenomegaly as well. Treatment is very difficult. They need to follow a very low-fat diet lifelong. So we're talking about a few teaspoons of fat per day, and that's it. So it's very difficult to do. Fortunately for them, there's some emergent treatments such as ApoC3 inhibitors. So we'll talk about that later. MCS is a much more frequent condition affecting 1 in 600 individuals, although the prevalence is probably increasing with the increase in obesity and diabetes. It's a disease associated with the accumulation of chylomicrons, but also VLDL and these remnant atherogenic lipoproteins. And the inheritance is complex, either oligogenic, polygenic, but again, with a strong contribution of the secondary factors as well. So the genes involved are pretty much the same genes involved in FCS, but most of these patients will be, some of these patients will be heterozygous carriers of mutations in these genes, whereas other will have polygenic increase in triglyceride due to the accumulation of multiple SNPs associated with high triglycerides. And there's more than 40 genes that have been associated with high triglycerides. So it's a disease often of adulthood, but with the onset of childhood obesity, childhood diabetes, we're starting to see these case reports of MCS in children and the pancreatitis in children. Pancreatitis is quite prevalent, 10 to 20% of patients, but of course less prevalent than an FCS patient. But since this is quite a frequent condition compared to FCS, most of the patients you see at the ICU, at the ER, with a hypertriglyceridemic pancreatitis will be MCS patients. These patients can also experience nausea, vomiting, recurrent abdominal pain, the same physical findings, eruptive xanthoma, lipemia retinalis, and hepatosplenomegaly. Fortunately for these patients, they respond very well to dietary changes and the treatment of secondary factors and to pharmacological treatment like fibrates and omega-3 fatty acid that are usually useless, that not very useful in FCS patients. Okay. So how do we differentiate these FCS from MCS in the clinic? There's a large phenotype overlap in these patients. In the past, we used lipoprotein electrophoresis or ultracentrifugation, but these tests are not easily available. We can also use some genetic testing, but again, it's not widely accessible to the primary care physician. So our question in one of our studies was to ask if we could differentiate FCS from MCS using simple clinical variables. So here's our cohort. We had the 25 FCS subjects and 36 MCS subjects. We could clearly see that the FCS subjects were referred earlier, had an earlier age of first manifestation, had a lower BMI, lower systolic blood pressure, and better habits than the MCS patients. If we look at the recurring abdominal pain, it was quite frequent for the FCS patients compared to the MCS patients. So that's another significant difference between these two groups. Unfortunately, you could clearly see in our cohort, the prevalence of pancreatitis in the FCS patient is quite high. 60% of patients had at least one episode, whereas in MCS patients, it was 10 times lower. And unfortunately, these FCS patients often have multiple episodes of recurrent pancreatitis, sometimes leading to chronic pancreatitis or pancreatic insufficiency later in life. Fortunately for them, it seems like they don't have an increased risk of cardiovascular disease, whereas the MCS patients have a higher risk of cardiovascular disease. Okay, if we look at biochemical features differentiating these two groups, we can definitely see that FCS patients have lower total cholesterol, lower LDL measured by ultracentrifugation, lower HDL, lower non-HDL as well. Whereas the MCS patients tend to have higher fasting glucose, higher liver enzymes, probably due to more hepatic steatosis. So we try to use a model to predict FCS or MCS in this population. And we can clearly see here, so that the strongest predictor would be the age of first manifestation. Lower BMI would be a predictor of FCS, and lower GGT is also a good predictor of FCS. Since then, there's scores that have been published to try to differentiate FCS from FCS in the clinical setting. Okay, so let's talk about severe hypertriglyceridemia and the risk of pancreatitis. So the risk of pancreatitis increases progressively as triglycerides are above 5 millimoles per liter. So 5%, the prevalence of pancreatitis is roughly 5% for patients with triglyceride above 10 millimoles per liter. And unfortunately much higher, 10 to 20% for patients with triglyceride above 20 millimoles per liter. So hypertriglyceridemia is present in roughly 9% of acute pancreatitis cases. So it's important to measure the lipid profile in these patients, and even more in pregnant patients with acute pancreatitis, where this represents nearly half of acute pancreatitis. So hypertriglyceridemia is unfortunately associated with a worse outcome in acute pancreatitis. There's a much higher admissions to the ICU. There's a longer length of stay in hospitalization, and unfortunately, a higher rate of mortality than other causes of acute pancreatitis. So what causes pancreatitis and hypertriglyceridemia? So the underlying cause is thought to be these chylomicrons. So it's not the VLDL or the other lipoprotein, it's thought really to be the chylomicrons. So these very large lipoproteins are thought to cause a sluggish circulation, maybe to impede capillary circulation, and cause ischemic damage to the pancreatic acinar cells. And these damaged cells can release enzymes like lipases into the interstitium, leading to triglyceride hydrolysis and free fatty acid release. And it's thought that maybe these free fatty acids can cause further cellular damage through endothelial dysfunction and damage, vascular leak, mitochondrial toxicity, and many other factors as well. Okay, so we've seen from our previous studies that not all MCS subjects will develop pancreatitis. We see that it's roughly 6% prevalence. So how could we differentiate the patient at risk from the patient that has a lower risk? So that's one of the questions we're asking. So what could be the genetic factors contributing to this heterogeneity? So we recently worked on 2 different projects. So we had 2 hypotheses. We thought that perhaps rare variants in the LPL or LPL regulating gene could, of course, affect triglyceride concentrations, but also the risk of pancreatitis. We also thought that perhaps variant, so single nucleotide polymorphism that were identified in large GWAS studies to be associated with pancreatitis could also increase the risk of pancreatitis in severe hypertriglyceridemia patients. So we look at these 2 different projects in our cohorts. So the objective 1, so is there a difference in severity complication of MCS according to the presence of a heterozygous rare loss of function variant in LPL related gene? So we identified now our cohort has grown significantly. We have 75 subjects with MCS, 29% of which are carriers of rare variants. So you clearly see that in severe hypertriglyceridemia, these rare variants are not that rare, nearly present in 1/3 of patients in the heterozygous form. So we compare the characteristics of the MCS subjects with and without a rare variant to the 28 homozygous FCS monogenic subjects. So here you can see there appears to be a gene dosage effect. So the patients that have severe hypertriglyceridemia but don't carry a mutation in LPL or related genes seem to have a milder phenotype compared to the patients that do carry a heterozygous mutation in LPL or the related genes that have a milder phenotype than the homozygous patients that have two mutant alleles. So we can see here that the age of referral is younger in the mutation positive patients compared to mutation negative patients. The first manifestation seemed to occur earlier as well. We see that these patients perhaps had a better lifestyle than the mutation negative patients. More importantly, we see that doesn't seem to be a difference in the average triglyceride in these patients that is significantly higher in the FCS group. But if we look at the maximum value of triglyceride, that's probably a better predictor. This was significantly higher in the patients that were mutation positive. And these concentrations were very similar to the concentration observed in the familial chylomicronemia syndrome patients. We do see a very interesting gene dosage effect looking at ApoB. So in the absence of mutations, the ApoB was significantly higher than the heterozygous carrier and then in the homozygous carrier of LPL-related gene mutations. More importantly, we do see this gene dosage effect on the risk of pancreatitis. So FCS patients, so patients with high triglycerides, but in the absence of a mutation, had a prevalence of pancreatitis of roughly 9%. This was very significantly increased to 41% in the carriers of one of these loss of function mutations, and as we mentioned previously, much higher in the homozygous carriers with a 61% prevalence. And this is true as well for the recurrent pancreatitis, where there was a significant increase for heterozygous carriers of these mutations compared to the non-carriers. Both of these groups had a significantly higher risk of cardiovascular disease compared or tended to have higher cardiovascular disease than in the FCS group. So again, it seems like maybe looking at these mutations can help us in stratifying risk. Also, we saw that the age of first pancreatitis appeared to be younger in the mutation-positive group compared to the mutation-negative group. Of course, it was much younger in the FCS group. We tried to see if we could, with univariate and multivariate analysis, if we could predict, if we could find predictors of pancreatitis in these MCS, severe hypertriglyceridemia patient, and we did identify several. So having a low ApoB in hypertriglyceridemia is a risk factor for developing pancreatitis. Having a high GGT is a risk factor for developing pancreatitis with high triglycerides. Having a maximum TG value above 40 is a significant factor. As we mentioned, carrying a rare variant in the heterozygous form is a significant factor for pancreatitis. And interestingly, the consumption of high percentage of fructose in the diet, probably through soft drinks or juice, can increase significantly the risk of pancreatitis in these hypertriglyceridemic patients. All right, so let's move on to our second hypothesis. So we know that mutations in the LPL are associated with pancreatitis in hypertriglyceridemic patients. But what about other genetic predictors? So we looked at common polymorphism in the genes that are known to be associated with pancreatitis and GWAS and generated a polygenic score, and we tried to see if there was an association with pancreatitis in severe hypertriglyceridemia. So this was a retrospective study of 114 patients with MCS, 26 of which presented an episode of acute pancreatitis. So this is how we generated our polygenic risk score. So we used the 8 SNPs that were published in the large GWAS in these genes. So we genotyped them in our cohort. We created a weighted polygenic risk score to account for the phenotypic effect of each SNP locus. And we look at the association between this pancreatitis polygenic risk score and the occurrence of pancreatitis in patients with severe hypertriglyceridemia. So here are the characteristics of our MCS patients without pancreatitis and the 26 patients with pancreatitis. As you can see, and as we previously published, the patients with MCS and pancreatitis had a higher prevalence of, or there was more carriers of a rare mutation in LPL and related genes, 54 versus 22%. But these patients also had a higher polygenic risk score than the MCS patients without a pancreatitis. Other factors being lower cholesterol associated with pancreatitis, and the high max TG value was also associated. So interestingly, this polygenic score was a good predictor of pancreatitis in patients with high triglyceride. So we can see that these patients with high polygenic risk score for the pancreatitis risk score had a roughly threefold increase in the risk of pancreatitis. And there was a significant increase as well in the risk of multiple pancreatitis. So this is true if we separate according to the median of the polygenic score, or we study tertiles of this polygenic score as well. So this really suggests that accumulation of common variants in pancreatitis candidate genes measured with a weighted polygenic risk score is associated with pancreatitis in these severe hypertriglyceridemia patients. So we went further and we said, why not combine all the variables we have? So we combined the presence of a mutation in lipoprotein lipase or associated genes with the presence of a high or low polygenic risk score for pancreatitis. And we do see this, this step effect here. So patients with low polygenic risk score for pancreatitis and no rare variants in LPL have a significantly lower risk of or prevalence of pancreatitis compared to these subjects with high polygenic risk score for pancreatitis and the presence of rare variant. So again, both common and rare genetic factors appear to be strong predictors of acute pancreatitis in MCS and could be useful for used by clinicians to identify patients at a greater risk and perhaps use more aggressive treatment strategies. So what are the treatment strategies? How do we manage patients with pancreatitis and chylomicronemia? So if we look at the publication, most of the time, what's recommended is a conservative treatment. Patients should be put on NPO, IV hydration should be started, and just this approach will lead to a 70% reduction in triglyceride by 48 hours. Other approaches have been looked at, the use of insulin drips or heparin. So when we talk about insulin, it was suggested that perhaps 0.25 units per kilogram per hour should be used with or without dextrose to adjust glycemia. So the IV insulin infusion will lower triglyceride, perhaps a bit faster than the conservative treatment, although some studies suggest no added triglyceride lowering compared to conservative treatment. So it's not clear that there's a benefit here. Again, there's a controversy looking at the benefits of heparin IV infusion. Not all studies clearly show a benefit. So what about the use of plasmapheresis? So plasmapheresis can lower triglyceride by 50 to 90% after one session, but unfortunately, there's no benefit over conservative approach after 72 hours. So we can lower triglyceride faster, but after 3 days, we're at the same level. Unfortunately, there's also minimal outcomes data. There's no data showing a benefit on mortality or morbidity. And there are some risks, central line insertion and transfusion reaction. So definitely most patients should have this conservative approach, plus or minus fenofibrate or other therapies. And these other approaches can be used on a case-per-case basis. So we also wanted to look in our institution and at the SHIM, how were pancreatitis or hypertriglyceridemic pancreatitis managed? So there's very few health providers really know about chylomicronemia syndromes, both the multifactorial and the familial syndrome. And there's no study looking at the quality of follow-up post-hypertriglyceridemic acute pancreatitis. So we decided to look at this problem. So we wanted to look at the follow-up post-hypertriglyceridemic acute pancreatitis and to see if this type of pancreatitis had a worse prognosis than the non-hypertriglyceridemic acute pancreatitis. So the method, so we look at pancreatitis events at the MUHC and at the SHIM between 2012 and 2018. Our hypertriglyceridemic acute pancreatitis group was a patient that had an acute pancreatitis event with triglyceride above 5.6 mL per liter. And the control group was acute pancreatitis due to gallstone, and we matched them for age and sex. So we had, in this time period, 1,490 episodes of acute pancreatitis in these two institutions. Most of them we could not study because they were for other causes, most of them being gallstone, 781, alcohol being the second most frequent cause. Idiopathic is quite frequent diagnosis as well. Unfortunately, triglyceride measurement was done in only 1/3 of the idiopathic acute pancreatitis case. So I don't know how they came to this conclusion. I think triglyceride should be measured more systematically. And this is also the case with the diagnosis of other causes of acute pancreatitis. Triglyceride are not measured frequently. So we're left with 44 patients with hypertriglyceridemic acute pancreatitis. We had to exclude 4 because of missing data, and then we had 40 for our analysis. So if we compare these 40 patients to the 88 patients with non-hypertriglyceridemic acute pancreatitis, And we clearly see that the hospitalization duration is significantly longer for patients with hypertriglyceridemic acute pancreatitis. These patients had tended to have a higher prevalence of a severe Balthazar scar as well, so more severe pancreatitis, and the higher frequency of admission to the ICU. So definitely these are poor prognostic markers. Of course, these patients have significantly higher triglycerides. Interestingly, their maximum lipase was significantly lower than the non-HDG AP, probably due to the fact that these patients are the mechanism due to causing AP in these patients is due to the gallstone that is known to cause much higher elevation in lipase. So, of course, the patients with hypertriglyceridemia also had a higher prevalence or history of diabetes than the non-hypertriglyceridemic AP. Okay, so if we pool all the cohort together, triglyceride is a strong prediction of admission to the ICU. So we see these patients with higher admission to ICU had a significantly higher triglyceride than those that did not require admission. So how are these patients managed at discharge from the hospital? So unfortunately, at discharge of these 40 patients, only 5 of them had a new prescription of fenofibrate. 9 of them had a previous prescription of fenofibrate, but 25 of them, they had no prescription, unfortunately. What about referral and follow-up? Well, here we only had 14 of these patients that had referral, 5 to the lipid clinic, 6 to endo, 1 to gastro, and 2 to other types of clinics. 18 of the 40 had no follow-up. So definitely this is a big problem. So we need to reassess how we follow up and how we treat these patients. At the SHIM, we identified 5 potential FCS patients that were referred, 1 that was a known patient, and at the MUHC, we had 2 possible FCS patients, 1 that was previously known. So it's important to work up these patients to better identify these cases and to treat them more efficiently. So what about novel triglyceride lowering therapies? So as we mentioned, ecosyl pentethyl or Vasipa, that is omega-3, it could be used, but it's not a very efficient medication to lower triglyceride. There's only a 19% reduction in triglyceride. It's much more efficient to reduce the risk of cardiovascular disease. So studies have shown a 25% risk reduction in cardiovascular disease in hypertriglyceridemic patient and secondary cardiovascular prevention or hypertriglyceridemic patients with diabetes. So really, ecosyl pentethyl is a medication used to reduce cardiovascular risk. We have novel therapies that have shown a lot of promise to reduce triglyceride. So ApoC3 inhibitors have been shown to lower triglyceride by roughly 50%. They're under investigation for pancreatitis risk reduction and ASCVD risk reduction in MCS patient. But recently, a study in the New England Journal of Medicine shown that in FCS, so the monogenic form of severe hypertriglyceridemia, olezarsen reduces triglyceride by 43% and reduces the risk of acute pancreatitis by 88%. So definitely a very promising drug that's probably soon to be approved by the FDA and Health Canada and to be a big game changer in the treatment of this disease. There's also NGPTL3 inhibitors that are shown to lower triglyceride by 50%. These drugs are already approved by Health Canada to lower LDL in patients with homozygous familial hypercholesterolemia, but there's also studies looking at lowering triglyceride and cardiovascular risk in patients with hypertriglyceridemia. So here's my conclusion. With a patient if your patient has high triglyceride, you should define your non-HDL or ApoB goal. You should look at secondary causes and try to treat them. You should implement a healthy lifestyle because this could be very efficient. If your non-HDL goal is not achieved and the triglyceride are under 10 millimoles per liter, your primary goal is to reduce cardiovascular risk and therefore lead to further non-HDL reduction, possibly by the use of statins and other LDL reducing agents. You could consider fibrates or omega-3 fatty acids as well. In patients that have high triglyceride above 10 millimoles per liter, the primary goal is to prevent pancreatitis. We should definitely intensify lifestyle changes, consider fibrates, and omega-3 fatty acid. In patients that have FCS, MCT oils can be used. we should definitely refer these patients to a lipid clinic. And if after all this, the triglyceride remain above 10 millimoles per liter, we should consider experimental therapies to further lower triglyceride and the risk of pancreatitis. So here are the take-home messages. So in patients with acute pancreatitis, we should measure triglyceride more systematically. We should refer these patients to the lipid clinic in the case of severe hypertriglyceridemia. If we don't, these patients will have recurring events and will go back to the ER and the ICU, unfortunately. Determining the molecular cause of severe hypertriglyceridemia could be useful to stratify the risk of pancreatitis in these severe hypertriglyceridemia patients. A pancreatitis polygenic risk score could, in the future, maybe help clinicians determine the patients that would benefit further or benefit more from these novel therapies. And emerging therapies, ApoC3 inhibitors, ANGPTL3 inhibitors, are currently investigated and could really improve treatment outcome in these patients. So, of course, I want to acknowledge all the lipid clinic team, my research coordinator, Martine Paquette, the fellow that published 4 of these most recent papers that we did on severe hypertriglyceridemia. So Dr. Simon Pierguet, who was a fellow in genetics from McGill, and now works at the CHUS, and of course, all the rest of the team here, the nutritionists, nurses, etc., as well as our collaborators. So thank you very much. Questions?
Thank you so much. Really a very interesting lecture, and congratulations on the work you've done advancing this field. Thank you very much for sharing this with us. Sasha, you have a question.
I was just, it's so nice to see somebody use like the data that's generated at the MUHC. So I just wondered how you identified the cases. Was it from people who normally would be consulted to treat pancreatitis that you have a registry, or is it another way that you identified the cases?
So basically, we went to the archives and extracted the ICD-10 codes for acute pancreatitis, and then we went to each of these patient files and identified the most plausible cause. So we look at the patient files pretty much. I don't know if that answered the question or not.
Does that answer your question, Sasha?
Yeah, thank you.
There's a question about statins. How much should they decrease triglycerides, and is there any that are better than others?
Yeah, so that's an excellent question. And yes, statins can lower triglycerides. So there's some data that perhaps high intensity and high doses of statins are more efficient to lower triglyceride than the low potency statins and the lower dose. And perhaps atorvastatin is slightly better than a rosuvastatin to lower triglyceride. But these are not the most efficient drugs. Usually we can, at a high potency, high dose statin, we can lower triglyceride by roughly 30%, whereas fibrates such as fenofibrates tend to lower triglyceride by more than 50%. But so it's something to consider as well, yes.
Okay. The pancreatitis, all these patients who are getting these recurrent pancreatitis, is that increasing the risk of pancreatic cancer?
I didn't see any data going that direction. In the clinic, I do see some anecdotal data. I've seen some patients with chronic pancreatitis developing pancreatic cancer, but I'm not sure that there's a clear link. Of course, the problem with recurrent pancreatitis is chronic pancreatitis and pancreatitis insufficiency, both exocrine and endocrine, so secondary diabetes, and of course, a problem with this digestion. So these are very serious conditions. And unfortunately, we do see those problems in our severe FCS patients.
Joyce, did you want to unmute for your question/comment?
Sorry, okay. This was a question about alcohol-induced pancreatitis. So these patients, what I've seen, often have elevated triglycerides, presumably secondary to the alcohol. But sometimes I find it difficult to sort out. Is it the triglycerides causing the pancreatitis, or is it just a side effect of the alcohol? How do you work that out?
Yeah, that's a very important question, and it's very difficult to differentiate both. Of course, if you have prior data, so showing that the patient had hypertriglyceridemia with low alcohol consumption, then you can perhaps have a better diagnosis. But both of these are intricately linked. Alcohol consumption is one of the best way to increase triglycerides. especially in patients with underlying genetic predisposition. We see very severe increases that can last up to 72 hours in the patients that have a mutation in LPL and that take alcohol. So it's important. It's not always easy to differentiate, and that's why in our studies we wanted to exclude patients with a severe alcohol intake to try to look more at the genetic or other causes of hypertriglyceridemia. But those are linked, and alcohol by itself is perhaps toxic to the pancreas as well. Is it purely through the triglyceride elevation, or is there another mechanism? It's not 100% clear, but probably a bit of both.
So if the patient, say, was abstinent from alcohol for a couple of weeks, and the triglycerides did not come down, would that be sort of long enough to assume that it was perhaps a genetic or other cause rather than the alcohol?
Yeah, absolutely. I mean, as I mentioned, the effect of alcohol may last up to 72 hours, but after a couple of weeks, definitely we're not seeing the effect of alcohol. So there must be another factor. And we should also look at this other possible secondary factor, diabetes, obesity, diet, etc. But then if those are ruled out, possibly a genetic contribution for sure.
Thank you.
No problem.
Just a little further along those lines, in terms of secondary hypertriglyceridemia, in terms of like absolute numbers, how high can it go and how quickly, what you talked about 72 hours of alcohol, but generally speaking, you see somebody who has very high triglycerides, you ask them a few questions and turns out that they've had a very poor diet or they've, have risk factors. How high could it go, and how quickly would you repeat it before you start to get alarmed? How quickly can you repeat it and expect to see a drop?
So that's an excellent question. And one of the problems with triglyceride is there's nothing more labile than triglyceride. Maybe CRP is on the same level, but it's extremely variable. So many things can vary, make the triglyceride vary. So obviously the diet, alcohol, we mentioned that. The weight changes in the patient, physical activity can have an impact as well. So there's a lot of things that can vary the triglyceride. One of the most important factors is fasting. So in the lipid clinic, we always ask for fasting lipid profiles, but outside the lipid clinic, more and more we obtain non-fasting lipid profiles. If the triglyceride tend to be high-ish, the clinician should order a fasting lipid profile to make sure that could be an underlying genetic cause, or this is purely due to the diet. So it's important to differentiate. So to your question, most of patients that have a genetic predisposition to triglyceride but a healthy lifestyle usually have triglyceride under 10 millimoles per liter. It's when they develop another factor, like maybe they become pregnant, then insulin resistance goes up, and then maybe their triglyceride increases drastically to these levels that put them at risk of pancreatitis. So it really depends on the interaction between the genetics and these secondary factors. And often both are needed to trigger these very high triglycerides. And again, triglyceride vary very quickly. So as you can see from these AP patients, even after 24 hours NPO, the triglyceride drop very significantly. So after 48 hours, they drop, in many cases, close to normal as well.
Fantastic.
So yeah, it can vary a lot and very quickly.
Thank you very much for that. David, any comments to make in terms of people here in the audience who want to refer patients? Maybe just walk us through it and the clinic overall. David, any other comments?
Our lipid clinic is through the division of endocrinology, so referrals would have to go to the endocrine clinic, and we will see them. Can I ask this question to Alexis? Do you want to comment on cardiovascular risk, triglycerides, and other risk factors? Because there is a bit of a controversy.
Well, sure, there's some controversy, but there's good evidence showing that the triglyceride associated with these cholesterol-rich lipoproteins, so remnant lipoproteins or remnant cholesterol, are quite atherogenic. So we have data from Mendelian randomization studies looking at genes associated with high triglyceride, but also Mendelian randomization studies looking at residual at the remnant cholesterol, and all those are really associated with cardiovascular risk. So I think the risk, the association with risk is pretty robust. Now, lowering triglyceride is maybe not the way. The way is lowering the risk, probably through established methods, lowering cholesterol. We see that Vascepa lowers triglyceride a bit, but has a profound risk reduction. So probably the benefit is not through triglyceride lowering. And ApoC3, well, the benefits, we don't know the benefits yet, but genetic studies have shown that patients with mutations in ApoC3 have lower triglyceride, lower remnant cholesterol, and significantly lower risk of cardiovascular disease, and perhaps low risk of pancreatitis as well. So we'll know in a couple of years when these studies have been published, but not all approaches that lower triglyceride maybe lower cardiovascular risk to the same extent. Whereas with LDL, it's a very simple situation. You lower LDL, you lower cardiovascular risk, pretty much with all mechanisms.
Good.
So we're running low on time. We're coming up on the hour. I'd like to, David, was there any other comment? Otherwise, we will close the rounds.
Well, maybe if I have a small comment at the end. So
yes.
If you have in your practice these patients with very severe hypertriglyceridemia, we're currently enrolling patients in clinical trials with these many different, we have FGF21 inhibitors, agonists, FGF21 agonists. We have these ApoC3 inhibitors as well. And so if you think your patient can benefit, you could refer them to the clinic and we could perhaps enroll them in these trials.
And the best way to refer them, is there a person to email or a number to call, or how would you suggest we do that?
It's going straight to, it's an endocrine consult.
Endocrine.
Yeah, and I would suggest that if you were looking for people, if you're thinking somebody's eligible for a study, put Alexis' name on it.
Fantastic.
Or more precisely, lipid clinic consult. Most of the time, that's what people wrote, lipid clinic, and we see them.
Fantastic. Well, thank you very much. Congratulations on your work advancing this field. It's great to see data coming out of the MUHC, so very informative. And thank you very much for sharing this very interesting presentation with us. Thank you, David, for joining us as well. And I wish everyone a wonderful afternoon. Thank you. Bye-bye.
Thanks. Bye.